Okay, so my name is Wasim. Today I'm going to present a literature review on what's there for obstructive sleep apnea in our patient population group. So I'm going to do a whole literature review as what's there for obstructive sleep apnea in end-stage renal disease and chronic kidney disease. Now there has been a lot of data about end-stage renal disease, so what at the end what I'll be doing is I'll be concentrating more towards the CKD. So our objectives today would be to discuss about the sleep apnea, its pathogenesis and model, do a literature review on sleep apnea and end-stage renal disease. This is what we already know. There's a lot of data about it. Briefly review role of nocturnal hemodialysis on obstructive sleep apnea. This is a current topic, and there's a lot of interest on it. And do a literature review on sleep apnea and CKD. This is what we are trying to know. There's very limited data on this. And then I want to do two article reviews today. One was presented at CHEST recently in 2009. This was a very good study that was done in America. It had some limitations, and that was the reason why I wanted to do another literature review. That was a Japanese study recently done and got published in Journal of American Society of Nephrology. And this was a very good study as well. So let's talk about sleep apnea. We know that there is a 2 to 4% prevalence of sleep apnea, but what is important is most of this remains undiagnosed. There has been a speculation that in our population, as far as around 70 to 85% of people have got some sort of sleep apnea that they are underdiagnosed or we are currently not diagnosing them. Sleep apnea, we all know, is a risk factor for hypertension, coronary vascular disease, CVAs, and death. And the pathogenesis for coronary vascular disease, because sleep apnea has been long associated with CVDs, is because you've got intermittent hypoxia, systemic sympathetic activation, systemic inflammation, and oxidative stress that leads to endothelial dysfunctions and atherosclerosis. What I want to stress today on sleep apnea is the role of sleep apnea in inducing sympathetic nervous system overactivation, which is not only an important contributor to cardiovascular morbid events, but also now there has been talks about that this SNS overactivity can induce CKD slash ESRDs in these patients, and volume and salt overload, which is a critical pathogenic factor of sleep apnea and end-stage renal disease, other than uremia. So if you look at the pathophysiology of obstructive sleep apnea and end-stage renal disease, uh, we know that there is a uremia that causes destabilization of your central ventilation control, causing sleep apnea. But recently they have been saying that it's actually volume overload that also contributes to development of obstructive sleep apnea in end-stage renal disease patient. And what volume overload does, it increases your upper airway obstruction and thus induces sleep apnea. And likewise, in our patient population and end-stage renal disease population, we do have diabetes, obesity, and cardiovascular disease that destabilizes our central ventilation control, causing sleep apnea. If you look at the classical model of sleep apnea, and I want to emphasize about the sympathetic hyperactivity, we do know that we have got a repetitive cycles of apnea, hypoxia, hypercapnia, and arousal. This not only leads to gas exchange abnormalities causing nocturnal hypoxia, leading to systemic inflammation and causing coronary artery calcification and oxidative stress, but it also leads to sympathetic hyperactivity. Again, with your apnea, hypoxia, you've got a abrupt generation of negative interthoracic pressure, which causes profound and sudden changes in cardiac loading condition, causing sympathetic hyperactivity. What this hyperactivity actually does is it increases your left ventricular hypertrophy and causes hypertension and cardiovascular comorbidities. Uh, and this has been a talk in the past as well. If we look in this publication, it was done in 2009, got published in circulation. What they are actually talking, the lower left hand graph, what is talking about is our usual patient Monday, Wednesday, Friday dialysis. What they are trying to do tell us is that there is a buildup of fluid uh, while they are not on hemodialysis. On the day of dialysis, we do an ultrafiltration, we take the fluid out, and then there is a gradual buildup of fluid again in consecutive 1 to 2 days. What the graph on the right hand side is showing is that it's a Cox regression model. They studied around 34 1,000 patients in this study. The gray bars, the gray long-standing bars, is actually telling us what their ratio was in terms of how much fluid they were taking out. So the higher the bars, the more patients getting that particular fluid. So the most higher fluid they were taking out was around 2 to 5 and 2.5 to 3 liters. Their mean was around 1.5. One Their mean was around 1 to 1.5 liters. And again, the same graph basically showing the COX regression levels, and it's showing us that when we do a case mix, and the case mix actually uh, includes or adjusts age, sex, diabetes, other comorbidities, and smoking. As we go up, our cardiovascular mortality goes up. So the higher the fluid you pull out during the dialysis, the more their mortality is. And then they adjusted the case mix with MICS, which is basically your malnutrition, inflammation, cachexia syndrome, and still adjusting to that, the mortality was going up in these patients. There had been a Canadian study done in the past, and it's a very interesting study. It was published in 2009 in American Journal of Critical Disease. What they were trying to find out is, change in your leg fluid volume and the incidence of apneic hypoventilation index. So the more fluid you are taking out from your legs, the chances of getting a apneic hypoventilation index was going up, so there was more chances of getting obstructive sleep apnea. What they were trying to say is that, as your fluid is going up from from your legs due to dependent edema at night time, your obstructive sleep apnea was getting worse, and there is a J curve for that. So the more fluid you are moving from your leg at night time, the higher your apneic sleep apnea hypoapnea index is. And this correlates in a linear pattern with your change in the neck circumference as well. So obstructive sleep apnea and end-stage renal disease, what we know is that around 30% of patients usually suffers from sleep apnea, but observational rates can be as high as 73%. What they are saying is that we are underdiagnosing obstructive sleep apnea and end-stage renal disease, and actual incidence can be a lot more than what we already know or studied. Sleep apnea in dialysis patient is thought to be a manifestation of uremia, and thus occurs at the late stage of CKD. That's what we know. But again, like I told you, there has been just not the uremia. It has been a volume overload issues that causes sleep apnea, and this volume overload is directly proportional to your cardiovascular outcomes, as what we have earlier seen. Uh, this is a new study what they are doing. This is a dynamic MRI sleep study, dynamic MRI during the sleep. And what is it is showing that instead of doing polysomnography in these type of patients, which is not only a cumbersome procedure to do, but also required a lot of a person to study it later on. What they are doing it at night time, they are doing a MRI study. This is a dynamic MRI, and what it is showing is, I don't have a marker here, but what it is showing is, you can see a patient having a obstruction of this upper airway, and this patient was an end-stage renal disease patient. And again, we know that sleep apnea causes sympathetic hyperactivity. So this was a study that was done in end-stage renal disease group. It's a fairly old study. What it showed in the third graph, you can see the hemodialysis non-nephrectomy group. We know that they have got a very huge sympathetic activity as compared to normal subjects, which is far off. So we know that their sympathetic activity is higher up anyway. And if we look at the data, what data do we have with that high sympathetic activity, what it does to our patient population? We know that, the higher the sympathetic activity is, the higher is the chance of death. And if we look at the cumulative survival scores in these patients, the cumulative survival score was very low in patients who have got high norepinephrine levels, as shown in the graph in front. And not even the sympathetic activity. There have been studies done that showed oxygen saturation, the effect of oxygen saturation and cardiovascular complications in dialysis patient. And what they found out that as your oxygen saturation drops down, there is a high chance of deaths in these patients. In fact, even a 1% decrease in oxygen saturation is associated with around 33% increase in fatal and non-fatal cardiovascular outcomes. So we know that there is a data. And what they are saying that in this study, if your oxygen saturation is less than 95% or around 94%, your cumulative survival scores or survival comes down drastically. And this was a very interesting study. This study actually, what they tried to figure out is, if we start doing a nocturnal hemodialysis on the patients, what will happen? So what this study was aiming was, they had patients on conventional hemodialysis, and they were trying to switch them from conventional hemodialysis to nocturnal hemodialysis. What they did is, and during this study, they did a very cool thing by doing polysomnography so that they exactly know where they are standing and what will happen once they do a nocturnal hemodialysis. So when they recruited the patient, they did a polysomnography on them on the day of their conventional hemodialysis, or on that particular night when they were on hemodialysis. Then they did the polysomnography 2 days after their hemodialysis, that is a day prior for them to get their another hemodialysis. Then instead of getting them a hemodialysis, a conventional hemodialysis, they put the patient on nocturnal hemodialysis. And it took them around 6 weeks to uh, to have a proper nocturnal hemodialysis regime for them. And then they had these patients for nocturnal hemodialysis at home for around 6 to 15 months. And they did polysomnography again on the day when they were getting the nocturnal hemodialysis. And by that time, after 6 to 15 months, these patients were very stable on nocturnal hemodialysis. So what they did is, they did a polysomnography on the day when on the night when they were having nocturnal hemodialysis, and then the next day before they were getting nocturnal hemodialysis, and look at the results. So on the far left, we can see that their apneic hypoapnea index was very high. That was 2 days after their hemodialysis. On the day of their conventional hemodialysis, it was around the same thing. Again, there is a fluid buildup. This was the assumption. When they were actually on nocturnal hemodialysis, their AHI index were drastically low. And what they were suggesting is that because they were pulling all the fluid out, uh, they had a they had an improvement in AHI index. And then when they were off nocturnal hemodialysis, it slightly goes up. There is one patient that was actually in black, where your AHI index remains same. This patient had a very bad AHI to begin with, and he had canny strokes breathing. So for him, nothing changed. But for the rest of patients, things changed drastically. The only pitfall with this study was they had only 7 patients on the study. Uh, so it was a very limited study. And what they were trying to suggest, you look at the bottom transcutaneous PCO2 levels, what they were saying is that their transcutaneous PCO2 levels were high, and this was driving their ventilation. And therefore their obstructive hypoapneic index was lower down. So talking about obstructive sleep apnea, its prevalence, we know that around 50 to 70 million people are affected with sleep disorders in the United States, and that's a very big number. We know that around 2 to 9% are female, around 29% are male. That would mean 1 in every 4 person out of us has got a sleep apnea. Uh, but this is very important. More than 85% of these patients have never been diagnosed, and this is where the problem is. The main important contributors is diabetes, hypertension, and obesity. If we look at this diagram, there is still a gray area where there is hypertension, CKDs, and sleep apnea merging together. What is causing what, we don't know. Is there any association between all these things? Yes, it is. Whether if we treat one of those things will help chronic kidney disease, we don't know. So there is still a lot of information that we need to pick on. And I think if we treat sleep apnea in these patients' disease, I think probably the CKD will get better. Uh, there had been a very good review article on managing sleep apnea and kidney disease, and why I'm putting this article in this table in is because we have done a lot of work on our hemodialysis patient group. If you look on the right hand side, they had a lot of studies done on hemodialysis patient and even on peritoneal dialysis. But look at the CKD, there is nothing much work done. There is still a very big gray area where we need to figure out what's going on. So I think there is a wake-up call on CKD and sleep apnea association. We know that there has been an increase of around 30% increase in incidence of chronic kidney disease in the last decade. We know that there are around 50 to 70 million people in USA that suffers with obstructive sleep apnea. We also know that hypertension, diabetes, and obesity uh, are the same contributors as CKD as they are for obstructive sleep apnea. So what I was trying to think was that is there any early screening and treatment for sleep apnea present that we can do in early CKD that can actually change our approach to prevent CKDs in a huge patient population group. We know that obstructive sleep apnea causes chronic intermittent hypoxia that induces oxidative stress and inflammation. It induces endothelial dysfunction, and this technically produces proteinuria or your decrease in GFR. We also know that sleep fragmentations or or arousals during sleep apnea during CKDs causes your increased sympathetic activation or RAS activation, and that causes hypertension, fibrosis, and glomerular hyperfiltration. Thus induces proteinuria, but we don't have good studies to figure out whether uh, treating obstructive sleep apnea can actually give benefit to CKD. And this is why you know there is no clear-cut evidence. There is no population-based estimates on obstructive sleep apnea and CKD exist. And however, there is an evidence that it disproportionately impacts patients with CKD. And this is the reason why I was inclined of presenting this paper and do a review on this. Uh, this was a very good paper that was done through Kaiser Permanente, South California. It was a cohort study. What they wanted to do is to determine whether there is any association between sleep apnea and CKD before occurrence of end-stage renal disease, and accounting for major comorbidities include diabetes, hypertension, CHF. Their hypothesis was that the risk of sleep apnea would increase at a lower level of EGFR, meaningly the CKD would lead to sleep apnea. What they did was they recruited all their own patients. All members had a similar health care coverages, so it was not like one patient had a better healthcare coverage than the other. They were all getting the similar treatment options and modalities. They included adults that were more than 70 years of age. They had the healthcare plan for more than 1 month, and their EGFR was more than 15 mLs, meaningly they were not any stage renal disease patients. The study time frame was around 3 years. It started from January 1st, 2002 to December 31st, 2004. Um, Sleep apnea was diagnosed by ICD coding and current procedural terminology for PAP devices. And that was actually a pitfall in this study because they were actually using the coding. They were not doing any studies to determine whether the patient has got a sleep apnea or not. They were just following through the ICD coding, or whether they were using the uh, positive airway pressure devices. Kidney functions was determined by EGFR through MDRD calculation, and that was another pitfall of this study. And logistic regression was used to estimate the relative risk for the patients who develop sleep apnea. And the only exclusion criteria for patients for them was patients who had an acute kidney injury and an EGFR of less than 15. So any stage renal disease patients, they were trying to exclude them from the study. For acute kidney injury, what they were trying to do is they were doing serial creatinine on these patients. They had a logarithm, which they did not mention on the study, but they had a logarithm. They were serially checking their creatinines, and they were excluding the patients who had AKI as per their logarithm. And the study group was a lot. Around 1100 into 119,000 patients were included in the study group. 80% of their original population had got CKD, meaningly the EGFR was greater than 19 but less than greater than 15 but less than 90. So out of 13,700 and around 13,077 427,000, we had 80% patient population that had actually got the CKD. What they did later on was that they divided the patient population in three models or three groups. Group 1 or model 1 was controlled with age, sex, and race. Model 2 included diabetes and congestive heart failure, and Model 3 included not only A sex race, diabetes, CHF, but they included hypertension. And what they were trying to figure out is, they were trying to measure the other covariates, and they were trying to assess what their incidence of sleep apnea is, and these multiple covariates. And they use logistic regression uh, as in statistics. So if you look at the table, uh, they had more female patients, so more than around 60% or 61% patients were female. Uh, the distribution on age was fairly equal. They had more non-black patients in their patient population, and we know that sleep apnea is more in blacks. And other than that, they had more hypertensive and diabetic in their patient population. CHF was only present in 3.45%. And if you look at this table, what they try to do is they try to look at the EGFR and the diagnosis of sleep apnea. So what they were trying to do is I've broke this table into two. On the left hand side of the left side of the table, what we can see is obstructive sleep apnea in their study group was more in patients with EGFR of around 75 to 60%. And then as the EGFR was coming down, the prevalence or incidence of sleep apnea in this patient population was less. And this is the odds ratio for sleep apnea by subjective characteristics. And what they try to figure out is that with outpatient visits, diabetes, CHF, and hypertension, they do have a high relative list or high relative list of sleep apnea. So with the more outpatient visits these patients have got, they had more chances of having sleep apnea. The if there were more diabetics, they had more chances of sleep apnea, and the model 3, obviously hypertension, their odds ratio of developing sleep apnea was very high, around 1.75. And if you look at the distribution on patient, because there was a problem with them actually identifying who had sleep apnea to begin with. The patients who were actually on positive airway ventilation device, the incidence of sleep apnea was not big difference than the ICD coding. So the chances or their risk of sleep apnea was fairly equal with not only patients who had ICD coding but who were on positive airway ventilation. And this was the table that they were showing that. And one thing I forgot to tell you, if you come down on the lower side of the EGFR strata, the incidence of having an obstructive sleep apnea was less than 1. And this was a confounding factor in this study, saying that what they were not trying to understand is why your incidence of sleep apnea was coming down as your GFR is going up. That was very unusual for this study. So what they try to do is they try to figure this out, and then they try to figure it out through by determining how many deaths occurred in these patient populations who had a lower GFR. And they found out that because of all the cardiovascular comorbidities and other comorbidities, the death in these patients was significantly higher as compared to these to other EGFR patients. So what they were trying to suggest was, because of the increased death in these patients, the chances of having a sleep apnea was actually lower down in the lower EGFR strata patients. So the results, what they summarized was that the overall prevalence of sleep apnea was only 2.5% in this patient population. The risk of developing sleep apnea was higher up, as with the different EGFR. So the lower your GFR, the incidence of getting obstructive sleep apnea was higher up. The 3-year prevalence of obstructive sleep apnea was around 2.5% as stated, but with 63% males, and the mean age was around 55 years. And they were saying that the increase in risk of having sleep apnea persists in patients with EGFR more than 45 even after controlling the heart failure, diabetes, and hypertension. So even if you control these factors of CHF, diabetes, and hypertension, your independent risk of getting sleep apnea in a patient with GFR more than 45 is higher up. So what were the pitfalls of this study? It was a cross-sectional study, so that was a pitfall. It was not a prospective study. The overall prevalence of sleep apnea in this patient population was very low. It was around 2.5, and we know that our patient population has got at least 3 to 4% patient incidence of sleep apnea. There had been a shortcoming of validation of sleep apnea diagnosis in the patient population studied. 53% or more than half of these patients were diagnosed as sleep apnea by only ICD-9 coding. It was not a true mix of patient population studied. African American were underestimated for only 9%. They were more female gender, 61 as compared to male. So these were all confounding or biases in the study. And they used the MDRD equation to estimate the GFR, which we all know is not a good estimate of actual GFR. The other study that I wanted to present was done in Japan, and the reason why I wanted to put this study in is because it kind of decreased some of the pitfalls from previous study. Again, this study was a cross-sectional study. It was not a huge study. We had 100 patients. The study period was from May 2009 to April 2010, so it was around for 1 year. Patient was admitted for education for their renal disease. So these all were very stable CKD patients, and these patient population and they were admitted regardless of their sleep complaints. So they do not have any sleep complaints. They were just admitted in for their CKD educations and their therapy options for end-stage renal disease. They excluded hemodialysis patients, patients with acute kidney injury, patients with ACS, CHF, CVAs, and systemic infection. For the definitions, they use CKD as the same definition for GFR less than 60 for 3 months or presence of proteinuria for more than 6 months. They calculated eGFR through a modified equation for Japanese population. We know that these populations is different from our population group. The proteinuria was defined by urine dipstick more than or equal to 1 plus proteins for more than 3 months. For their definition of hypertension, they said that blood pressure should be more than 140 by 90, or they should be on some antihypertensive medications. For the definition of diabetes, they use the fasting blood glucose more than or equal to 126, random more than or equal to 200, and HbA1c more than or equal to 65%. For obstructive sleep apnea, and this was a good thing about this study, what they did was when the patient came in for their CKD education, they did polysomnography on them. Well, it was not a polysomnography. They had some portable devices that they used, which were very compatible with polysomnography. So they actually diagnosed the patients with sleep apnea when they were actually admitted for their CKD evaluation. The scoring of apnea and hypoapnea was done as defined by American Academy of Sleep Medicine. The statistical analysis they used was actually a logistic regression and a Spearman rank correlation, and their primary outcome was to find out the prevalence of obstructive sleep apnea and the severity of AHI in their patient population group. If we look at the characteristics of 100 patients that were included in their population, and again, these were non-hemodialysis patients, their mean age was around 65 years of age. There were more men in this patient population other than our study previously that I was talking about that had more females. Their BMIs was around 23.1, which is very typical for Japanese population. They don't have a very high BMI to begin with. Their serum creatinine was 2.11. Their eGFR was around 28.5. Diabetes were present in 31% of patient population. Hypertension was present in 80% of patient population, and pre-existing CVD was present in around 27% of patient population. And what they found out was that, and this is the distribution of various stages of CKDs in this patient population. So it varies from stage 1 to stage 5. But most of their patients was around stage 3, 4, and 5. what they found out was that in their patient population, for the 100 patients that they studied, their incidence or prevalence of obstructive sleep apnea was around 65%, which is very high. And most of these patients were actually in moderate to severe obstructive sleep apnea category. So basically, more than 25% or one-fourth of their patient population was actually in moderate to severe category of obstructive sleep apnea. And when they did the covariate analysis, so on the univariate analysis, what they found out that age, gender, and especially the male gender, BMI of more than 21, a high GFR, all are correlated, or they are all proportionate for them to develop sleep apnea. So the relative risk of developing sleep apnea with all these variables were in a linear progression. There is a very strong affiliation to that. And when they did a multivariate analysis, they found out that even if you decrease the GFR by 10 mils, their incidence or their chance to develop obstructive sleep apnea increases to around 42%, which was really high. In intergroup divisions, if you look at the patients with diabetes and pre-existing CKD, if they had diabetes, they had high chances of developing sleep apnea. And if they have a pre-existing CVD or cardiovascular disease, they were more prone to develop obstructive sleep apnea. And this is basically showing the same thing. For apneic hypoapneic index, what this graph is showing a linear correlation, and this is telling us as your GFR is coming down, your chances of having an AHI index is going up, meaningly there is more chances of these patients developing obstructive sleep apnea. And again, this is a Spearman correlation telling us that there is a clear-cut association between all the variables, including age, BMI, decreasing GFR, diabetes, and pre-existing CVDs, that are all related to their chances of developing sleep apnea. So in summary, this was a cross-sectional study. They found out that their patient population had a prevalence of around 65% for obstructive sleep apnea in patients who had non-hemodialysis dependent CKD. 1/3 of their patient population had moderate to severe obstructive sleep apnea, and this patient population again is a patient population who are non-hemodialysis requiring CKD. They were saying that the decreasing GFR is a strong predictor of obstructive sleep apnea, even if you adjust the different confounders. The different confounders in their study was age, BMI, diabetes, hypertension, and they are saying that even if you adjust these confounders, the chances of developing obstructive sleep apnea goes up if your GFR is coming down. In this study, age and gender were not associated with obstructive sleep apnea, so this is something that was new. The pitfalls of the study, again, it was a cross-sectional study. It was a small study as compared to our previous study. Only 100 patients were included in this patient population. The patient population belonged to a Japanese population, which is very different from our patient population in America. There was a selection bias present in this study. Only those patients were selected who were actually referred to nephrologists and they had a stable CKD, as compared to my previous study that I presented, where they randomly selected all the patients. So with this I end, and what I wanted to say is that there is a high association of obstructive sleep apnea with end-stage renal disease. We already know about it. We already know that treating patients with nocturnal hemodialysis actually improve their obstructive sleep apnea. We know that obstructive sleep apnea is associated with CKD. What we don't know and what we are not realizing is that if we diagnose these patients early, especially if we diagnose the patients with CKD who have sleep apnea early, and if we treat the obstructive sleep apnea, what would be their results? Will there be if this would be a preventive measure versus whether it will actually improve their overall GFRs in long term? Thank you.